Well, hello, my name is Michael Levy. I'm a neurologist and a associate professor at Harvard Medical School and Massachusetts General Hospital. And I'm joined today by Prem Subramanian at the University of Colorado Hospital, who's professor of ophthalmology there. And we have the pleasure today to discuss with you the topic of the eye on neuromyelitis optica spectrum disorder. And I'll start with the learning objective, which is to describe ophthalmological signs and symptoms in a person suspected of having neuromyelitis optica spectrum disorder in order to basically reduce the time to diagnosis. That's really the goal here, is to educate neurologists, ophthalmologists, and neuro-ophthalmologists about this disease, because we know that this disease carries significant consequences if not treated quickly. It can lead to permanent neurological deficits. And so now I'm going to let Dr. Subramanian talk with you more specifically about the ophthalmological issues in enema.
All right, thank you, Michael. And as he mentioned, this is really a course being aimed at primary eye care providers. So when a patient walks into your office with new unilateral or bilateral visual loss, and you suspect it might be optic neuritis, how are you going to determine that it is more likely to fall into the NMO spectrum disorder rather than the more typical and more common demyelinating optic neuritis that is classically associated with multiple sclerosis? I listed some symptoms here, but before I go into that, the first thing that always worries me is when the patient doesn't fit the typical demographics for MS-associated optic neuritis. So classically, that's going to be a Caucasian female, maybe in her 20s or 30s, that the median age for NMO spectrum disorder is 39 for the first event. So if that patient is a little bit older, then I'm more worried it could be NMO. Similarly, if that patient is not white, then I'm going to be thinking just a little bit harder that this might be NMO spectrum disorder. So those first things when the patient comes in my door are going to just heighten my suspicion. And then what am I looking for when that patient is in the chair? Bilateral optic neuritis is certainly more concerning for an NMO spectrum disorder. Typical optic neuritis can occur that way too, it's just less common. Severe vision loss, 2400 or worse vision. This is highly characteristic, though not a slam dunk, that it's NMO spectrum disorder. But when that patient is starting to get into that 2400 counting fingers, hand movements range, my suspicion for NMO spectrum disorder significantly goes up. A lack of pain. Seems counterintuitive, right? Because we typically say that optic neuritis is painful. But as I'll show you in subsequent slides, the inflammation in the optic nerve may be a little more posterior. It may even be intracranial rather than being intraorbital, and that doesn't produce pain. That does not produce pain, although it may give you the severe vision loss. Severe visual field defects typically go along with the severe reduction in visual acuity. The optic neuritis treatment trial told us that in typical demyelinating optic neuritis, you can see all sorts of visual field defects. It's not the type of visual field defect that makes me think of NMO, but rather the severity. If you are doing automated perimetry and you see mean deviations in the -25 or worse range, that again heightens my concern. And then finally, MRI findings. Patients, often when they reach me as the neuro-ophthalmologist, have already had an MRI of the brain done, and NMO doesn't give you the typical white matter lesions, periventricular white matter lesions that MS does. And patients will actually come in being happy that their brain MRI looks so-called normal, but that actually worries me more, because if they have some of these other features and a normal MRI of the brain, I'm starting to think that maybe they have some abnormalities in the spinal cord that we haven't found yet. So I'd like to walk you through a few cases that I think help to illustrate some of these points about when you should be thinking about NMO spectrum disorder in that patient who presents with the other signs and symptoms of optic neuritis, which of course would be a relative afferent pupillary defect in the setting of unilateral vision loss, color vision decrement, possible optic nerve swelling, as I'll show you, and then the visual field abnormalities. Here we have 4 cases of patients with optic neuritis, one of whom has typical demyelinating optic neuritis, and the other 3 who have some version of NMO spectrum disorder. And I will walk through what the differences are among them. The patient with MS, as I mentioned before, a little bit younger. She has pain, decreased vision. She does go down to about 2200. She has an RAPD, pain with eye movements, and an otherwise normal examination. An MRI shows a short focal segment of optic nerve enhancement intraorbitally, less than half the length of the optic nerve. And her MRI of the brain subsequently showed periventricular white matter lesions. These other 3 patients that I'll walk through have other signs and symptoms or demographics that help us to think that they don't fit into that category. So the first is actually one with a MOG-related optic neuritis. Dr. Levy mentioned that we have discovered this myelin oligodendrocyte glycoprotein-related antibody. Unlike the NMO, the aquaporin 4 antibody, it's not been proven to be pathogenic. It doesn't seem to drive the disease, but it is a biomarker that is associated with patients who have a clinical spectrum that looks like NMO, but may behave differently in that it is more steroid responsive and may respond differently in terms of its long-term management. Improvement also may be more likely with MOG-related disease. So this was a Black African-American woman, a little bit older, 37, otherwise healthy. She had a little bit of eye discomfort. She had blurred vision. Her vision had dropped over the course of time to the 2040 level and then worsened to the 2400 level. And she had subtle swelling of her optic nerve. That subtle swelling of her optic nerve, though, then led to a diagnosis of optic neuritis along with other clinical features, but she had a very significant enhancement not only of her optic nerve, but as you can see in the axial orbital MRI with gadolinium contrast with fat saturation, that there is a thickening of the nerve and significant enhancement of the optic nerve sheath as well. So a characteristic finding that we see in patients with MOG-related optic neuritis, and even if the visual acuity is not to the level that I mentioned before that raises my concern, if I see this kind of pattern of enhancement of the optic nerve and the optic nerve sheath, I'm going to be thinking MOG. I have to also think of all these other inflammatory or infectious disorders such as sarcoidosis, such as Lyme, and syphilis that can cause a similar picture, but MOG definitely needs to be on my differential so that I think of it, get the appropriate antibody testing, and potentially institute steroid therapy over a long time. And I think Dr. Levy and I will talk about that a little bit at the end. So let's look at a couple of cases that fit into the category of NMO spectrum disorder. This case here is of a 30-year-old Caucasian female. So again, a little younger than what we told you for NMO spectrum disorder, but she had right eye vision loss to the 2200 level, an RAPD, and her fundus was normal. And in addition to her fundus being normal, she had a longer segment of enhancement, as you can see on the axial orbital MRI with contrast. She had a longer segment of enhancement of that right optic nerve, nearly the entire optic nerve intraorbitally. And she had a normal appearing brain MRI, both by FLAIR as well as gadolinium enhanced sequences. So this case actually presented to me before we had widespread testing for NMO spectrum disorder, before there was easy access to the aquaporin 4 antibody test. But this is definitely an individual who, if they came into my NORD now in 2020 or 2021, I would be ordering that testing right away and instituting therapy in a manner that would be appropriate for NMO spectrum disorder. So this patient returned to see me with counting fingers acuity eccentrically in that right eye. Recall that the majority of patients with typical demyelinating optic neuritis will have a significant improvement by that 6-week time point, whether they undergo steroid therapy or not. So this was very concerning. She had received corticosteroids and her vision did not improve at all. Now she had no pain with eye movement. Her anterior segments were normal. She was developing disc pallor of her right optic disc, and she ultimately ended up having an MRI of the spine that showed a longitudinally extensive lesion, and she was diagnosed with neuromyelitis optica. But some other findings that are demonstrated on this slide, that if you are the one who makes the diagnosis and obtain an MRI, and I mentioned again, an MRI not just of the brain, but MRI of the orbits with fat saturation and gadolinium contrast, this may show you characteristic findings, again, from a different patient here with bilateral visual loss. You can appreciate the arrows pointing to chiasmatic enhancement and slight thickening in the setting of an NMO spectrum disorder disease. And so we have to look for these characteristic findings in our patients in order to not miss the diagnosis and in order to look for those appropriate signs that will lead to the diagnosis. So to sum up these cases, and then Dr. Levy and I will give a little perspective together on how we approach the diagnosis or the concern for patients with NMO spectrum disorder when they present. Patients who present with new subacute vision loss that is suspicious for optic neuritis based on clinical exam, if they have poor visual acuity, if they have severe visual field defects, if they are outside the typical demographics for typical demyelinating optic neuritis, and again, paradoxically enough, if they don't have pain, I am worried that they have NMO spectrum disorder. And based on what Dr. Levy told you on the timeliness of therapy being potentially critical for visual recovery, I am going to be operating under that working diagnosis and working to establish the diagnosis with appropriate serologic testing and additional MRIs. So, Dr. Levy, if you'd like to join back, we'll talk about when to suspect it from each of our perspectives.
Thanks, Prem. I completely agree with your assessment of the ophthalmological point of view, when to suspect NMO. From a neurologist point of view, anything that's severe to the point of vision loss or counting fingers, that I haven't seen that in MS in almost forever. And if the patient carries a diagnosis of MS and presents with that kind of presentation, it's a huge red flag for me. I just haven't seen it that much. Similarly, when a patient has a coexisting autoimmune disease like lupus or Sjogren's disease or psoriasis or vitiligo, that also puts NMO strongly in the center of the radar screen. And then anyone who has a previous history of a symptomatic transverse myelitis, where if they ever mention that phrase, transverse myelitis, or they're limping or have a history of something that's really clinically symptomatic, that also puts NMO square in the middle of that radar screen. So completely agree with your assessments.
And the one thing I didn't mention, Michael, is the importance of optic disc swelling. In typical demyelinating optic neuritis, the minority of patients have disc swelling. And so when a patient presents to me with optic neuritis and a swollen disc, and particularly if they have a lot of hemorrhage or lipid around the disc, then that is very uncharacteristic of MS and really makes me think of NMO spectrum disorder. And
can you see that on an OCT, optical coherence tomography? What does that look like if you were to happen to scan them in the office during an acute optic neuritis? So all patients with acute optic neuritis have some degree of thickening of the retinal nerve fiber layer. So if you do the peripapillary retinal nerve fiber layer, you will see a little thickening. So if we say 100 is normal, maybe 110, 120. But the kind of disc swelling I'm talking about would give you values in the 200s, 300s. So it would be evident, I think, that it's something different than the typical optic neuritis. The scan of the macular ganglion cell complex also can be helpful in people who have that available to them, because NMO spectrum disorders
tend to cause early loss of those macular ganglion cells, and the typical MS may not. And so if I see that, if the patient presents with that, then I'm much more worried that they could have an NMO spectrum disorder.
So I think, when we have patients who carry the aquaporin 4 seropositive diagnosis, I think we're much more aggressive with them because we know that that delaying care leads to permanent neurological damage. I think the harder task is what to do with those seronegative patients, especially those who've had an attack in the past, have been worked up, they tested seronegative, and now they come in with another optic neuritis. What do you do for them? Do you retest? Do you just presume that they have a seronegative disease? How do you manage them that's different from the seropositive patients who you already know have aquaporin 4 antibodies?
That's a great question. And I think we still go on a case-by-case basis for these individuals because you're right. It is not a clear-cut diagnosis like it is with the antibody positives. So take the scenario you presented. Someone shows up with their second event of optic neuritis, and some of it is going to depend on what I see in terms of their recovery from the first one. How convinced am I that it fit into an NMO spectrum disorder? I just mentioned some of the changes I look for in the fundus and on OCT to suggest it's an NMO spectrum disorder. They're more likely to have significant residual damage to those structures compared to someone who may have had more of a typical demyelinating event. But I'll work them up again. Just like you said, I'll test for the antibody in the serum. I find that's more useful than CSF. I know some people test CSF. I will image their spine again to see if there is a lesion that satisfies the criteria. But if they have evidence for damage just in the ocular fundus and they have a second event, I'm going to talk with them about being more aggressive because I'm worried they're going down a bad pathway.
And one of the core features of MOG antibody disease, we didn't talk a lot about MOG, but in patients who test negative for aquaporin 4, test positive for MOG, and they may have any presentation, usually optic neuritis in adults, if we withdraw their steroid treatment too quickly. Typically with aquaporin 4, I would put them on 5 days of high-dose steroids and try to bring them off 2-3 weeks, get them on a B-cell depleting drug. If we try that with MOG, we often will precipitate a relapse. And that's kind of one of the features of MOG that I've noticed that I don't see as much with aquaporin 4. And that could be true in the spinal cord or anywhere else. Is that just my perception, or is that also something that you're seeing as well?
No, I agree. It's something I see as well. In fact, I joke with the patients a little bit that I'm going to treat them with steroids. And if they get better really quickly on the steroids, it's good news and bad news because I'm then going to be worried about the MOG disease, even though, of course, I'm happy that their vision is recovering. And without a doubt, a slow steroid taper is necessary in these patients. And we're learning there is a category of disease in neuro-ophthalmology that has variously been labeled chronic relapsing optic neuropathy. And a lot of MOG seems to be fitting into that because this was a steroid-dependent optic neuropathy, a steroid-responsive optic neuropathy. And I manage the MOG patients in a similar way. I do think that we're now discovering what was actually associated with that disease that was really a descriptive term.
Plasma exchange is something that we've been initiating in patients with aquaporin 4 NMO who come in with a myelitis attack because we feel like, why waste our time with steroids? These attacks are severe. It leads to a lot of motor, bowel, bladder, and sensory issues and pain. And initiation of plasma exchange early in that course tends to improve their outcomes. Is that true with optic neuritis as well?
I think we're still accumulating the evidence as to how effective it is for the optic neuritis. We certainly in a patient who has an established NMO diagnosis, if they come in with an attack, we will not hesitate to start them on Plex quickly. And we have been aggressive in terms of starting them. We do start them on steroids if we haven't established yet that they have an NMO spectrum disorder and it is optic neuritis, but we have a low threshold. If they're not showing any improvement within 3 days and they have a significant reduction of visual acuity and their MRI looks more like NMO than MOG, then they're likely to start plasma exchange. So I agree. I think we're accumulating more evidence, and I suspect it's going to show us that even for optic neuritis, the early intervention with Plex is good.
Just to push that point, Mike, my colleagues in Germany look back at all of their cases of NMO attacks, and we have this slide here that demonstrates that if you initiate plasma exchange early, especially within day 0 or 1, the chance of recovery back to baseline is close to 50%, which is great for NMO. But then every category that you delay, if you delay 6 to 10 days, for example, from onset, and maybe we don't know exactly what the onset is, but by historical measure, if a patient says it started a week ago, and then you start plasma exchange, the chance of recovery back to baseline has dropped to in the 30 percentile range. And then if you wait 21 days or 3 weeks or more, the chance of recovery back to baseline is dim. And it's not just the binary response, return to baseline or not. It's also, if you also look at just poor recovery versus good recovery versus medium recovery, the longer you wait, the worse with plasma exchange. And I think they included optic neuritis in this series, but certainly a lot of transverse myelitis cases that tends to be the case. I wanted to ask you about the new FDA-approved treatments, which have been approved for aquaporin 4 patients only. But it's interesting when I've had these conversations, even with my neurology colleagues, there's been some hesitation to jump straight into these big new treatments as a first-line agent. They want to see more data. They want more safety data. They want to see how people do. And my feeling is that the off-label treatments don't have any data, any class 1 or class 2 evidence to support them. And I wonder how it is with neuro-ophthalmologists. Are you prescribing eculizumab, inebilizumab, and satralizumab as first-line agents for aquaporin 4 seropositive patients?
So we have, for our newly diagnosed patients, been starting them on one of those 3 therapies for exactly the reasons you mentioned. I'm particularly for those aquaporin 4 positive patients, the eculizumab data I think are very impressive in terms of prevention of relapse. And they have potential side effects. They need to be vaccinated for meningococcal meningitis and such, and just being aware of that concern. But I've, again, discuss it with the patient, but I do present it in a way that suggests that these therapies have good data behind them. And I do feel that I can rely on those data, and I would favor using them over other immunosuppressive or B-cell depleting therapies that we have been using for the reasons that you cited.
I do have a more difficult time with patients who are on rituximab and doing well.
Yes.
On other established therapies that were off-label initially. And if they're doing well, I have a hard time pulling them off and convincing them that they should go on something else. But certainly for new starts, I've been using the new treatments.
Yeah, absolutely. My approach is the same.
Yeah. Now, what is the team approach like where you are? Do you send, if you have a patient with just a history of optic neuritis who's seropositive, do you establish them with the neurologist, or only when there's more neurological issues, if they have a transverse myelitis or otherwise? Or do you create a team approach from the start?
We do create a team approach from the start. If the patient's presenting problem was optic neuritis and we make the diagnosis, then I'm likely to continue managing them, but they have seen one of my neurology colleagues and just had a conversation with them to make sure they understand what the disease ramifications might be and to see if they have any other questions about treatment options. So I think a team approach is always appropriate. That allows for you to decide who's going to take charge and then who's going to all assist in making decisions.
And so what if I have a new aquaporin 4 seropositive patient who's only had myelitis? Should I refer them to a neuro-ophthalmologist for just a kind of baseline exam or to check in? And how often would you want to see that patient who's never had an optic neuritis yet?
I would definitely recommend a baseline exam. They may have had a subacute event that either they improved from or that they didn't recognize because it wasn't bad enough and they didn't seek attention. So getting a good baseline is helpful if they are unfortunate enough to have a relapse that includes optic neuritis. And it's certainly reasonable for a neuro-ophthalmologist to see them on an annual basis. Again, that team approach of ensuring that we're not overlooking something.
I completely agree. Now, if this, one of the questions is when you encounter your colleagues at meetings, conferences, whatever, is there something specific about NMO, aquaporin 4, or MOG that you wish they knew that you're just like, why isn't this more well known? What do we really need to advocate and put out there for people to know about NMO and MOG?
In the eye care community, I think it would be recognizing who's at higher risk. That may not be as well recognized. So in the past few years, I think we've done a better job of heightening people's suspicion when someone has significantly reduced visual acuity or maybe a really bad visual field. But even those patients who aren't so severely affected, if they fall outside the typical demographics, I want my colleagues who are seeing these patients to know that, hey, this is a little funny and you ought to be suspicious.
I would say that my personal wish was that neurologists were more, I don't think the word is daring. I think the word is rely on the evidence when they choose treatments. I think that depending on your experience or what's the easiest thing to do administratively is not the right approach. I think we should be using evidence-based medicine to make treatment decisions. And that would be really in favor of the new treatments that have undergone blinded, placebo-controlled trials that are, peer-reviewed and very well evident. So that is my wish. Prem, I'd just like to thank you for your time and I look forward to doing additional CMEs with you in the future.
Thank you, Michael. This was a great event. Thank you.